Yeah. Now it is my pleasure to invite and introduce our chairpersons for the day. Our first chairperson, Dr. K. Raghu sir, who is senior cardiologist, consultant, care, super specialty hospital and transplant center, Hyderabad. So he's post DM. He has done FRCS Glasgow from UK, FRCS Edinburgh, UK. He has many scientific papers to his credit, published in national and international journals. He has delivered lectures at regional and national forums. Welcome, sir. Next, Sanjay. Dr. N. Sudhakar Rao, sir, our second chairperson. He's senior endocrinologist, former professor and HOD, Department of Endocrinology, Gandhi Medical College, Hyderabad. Sir has done his DM endocrinology from prestigious PGAMR in the year 1984. He's a former legislator, AP Assembly. His number of awards to his name, his lifetime achievement in endocrinology by Code Blue in 2015. He has many scientific papers to his credit, published in national and international journals, and has delivered lectures at regional and national forums. Welcome, Dr. Sudhakar sir and Dr. Raghu sir. Now I request Dr. Raghu sir to please give a brief about today's program. Over to you, Dr. Raghu sir, please.
Good evening, ladies and gentlemen. It's an honor to be here amongst you all, leading names, and especially noting all the lovely work that the Presentation of India has been doing. I think we're going to have a very exciting session today. Since the late 60s, when atherosclerotic coronary artery disease has become a factor in our life, and lately it has produced an explosion among Southeast Asians. There have been innumerable amount of research, and there has been an explosion, vertical explosion of knowledge on this subject. And yet, the vast majority of the scientific community, even amongst our physicians, it's very difficult for them to get to accept all the guidelines. In fact, even today, there are a few cardiologists who write both in the lay papers and in the scientific journals that the association between cholesterol, statin, and coronary artery disease for cardiovascular disease has not been adequately established. In this context, it's very, very relevant that we have this symposium today. And as Dr. Narsingan has pointed out, the work done by the Indian Association has been very, very important, especially because we know that we are possibly the highest percentile of risk in the world. And our risk factors are at times quite different. We face a different set of problems as compared to the Western and the Caucasian society. And I'm sure we will all learn from all the speakers and the moderators of the chairpersons. I welcome you all once again, and I hand over to Dr. Sudhakar to introduce the speakers. Thank you.
Dr. Sudhakar sir, yes, please.
Thank you, Dr. Harish and Dr. Raghu, my co-chair. It's a pleasure duty to introduce moderators. First moderator is Aman Salman. He's a DNB cardiologist from my Fellowship Intervention Cardiologist Singapore. He's a senior intervention cardiologist consultant care for specialty hospital. And he has many scientific papers to his credit, published in national and international journals, delivered lectures at regional and national forums. His topic is the culprit and the target in the ACCVD. Next. I have pleasure to introduce my close friend, G. Shanshekar Reddy, our senior endocrinologist and former professor at Department of Endocrinology now in Image Hospital. And 20 years he has Osmania Medical College, Osmania General Hospital. He is presently executive member of National RSSDA. He has many scientific papers to his credit, published in national and international journals. delivered lectures at regional and national forum. He is an active member of Endocrine Society Telangana branch. Topic, he academically attends all the important seminars and conferences. Topic 2, he will be chairing for this session. And DM is diabetic dyslipidemia, what is new? He will be chairing on that session. And Dr. Rajendra Kumar Jain, our senior cardiologist, cardiologist, KIMS Hospital, DM Cardiology from Nizam's Institute of Medical Sciences. Awards, leader in Green Choice of Award, Indian Heart Journal 2017, Best Review Indian Heart Journal 2016. He has many scientific papers to his credit, published in national and international journals, delivered lectures at regional and national forum. Familial hypercholesterolemia, an underdiagnosed, and undertreated entity. Next. I introduce all these topics, Chairman, and hand over the mic to the chairperson.
Thank you very much, sir. Now I request Dr. Jain sir, Dr. Rajendra Kumar Jain sir, to please introduce Dr. John Christopher and invite him for his talk and to moderate his session. Dr. Jain sir, please.
Thank you very much. I thank Torrent Pharma and Lipid Association of India for an excellent symposium today. It's very nice to hear all the stalwarts in lipidology. I have attended some of these programs by Dr. Raman Puri, Iyengar, and other people from the Lipid Society. I learned a lot, and I think all the people who are participating will learn a lot from this. I think we'll have the first topic by Johan Christopher, who's a good friend of mine, and he'll be talking on familial hypercholesteremia, an underdiagnosed and undertreated entity. And he did his DNB from Care Institute of Medical Sciences, Hyderabad. And his special interest is imaging, and has done a lot of work in cardiac MRI. And he has a lot of scientific papers to his credit, and he has delivered a lot of lectures. Over to John.
Thank you, Dr. Jain, for that kind introduction. Respected chairpersons, moderators, and my friends in the audience, thank you once again for this opportunity. Today, I'll be talking about the underdiagnosed, the undertreated, and life-threatening problem of familial hypercholesterolemia. And I think it is time for us to get familiar. With great credit to the Lipid Association of India, I will start my talk. All of you can see the world map, and you can see the areas in brown and orange and yellow are areas which have been mapped in terms of familial hypercholesterolemia. But you can also see that we live in the subcontinent here of South Asia, and sadly, we do not have any mapping of familial hypercholesterolemia. So I think with the work of the Lipid Association of India, I think it's a great moment for us to make that change and make sure that we are listed so that all the interventions and the great research work that is going on comes into this country and helps us get out of this very difficult problem. We're all aware of familial hypercholesterolemia, and we know that it is a very common genetic cause for premature coronary heart disease and calcific aortic valve stenosis. Familial hypercholesterolemia markedly reduces the liver's capacity to clear the atherogenic cholesterol-rich LDLs from circulation, with consequent accumulation of LDL in the blood. One baby is born with familial hypercholesterolemia every minute, so it is a fairly common genetic problem. Unfortunately, it is underdiagnosed and untreated, and hence very systematic screening strategies have to be used, but which are not really implemented. A little overview on the schematic, you will see the yellow particles are the LDLs, and they go towards the cell. The ApoB is in pink, which is a ligand binding the LDL particle to the receptor. The green columns are the LDL receptors on the liver cells, which bind to the ApoB and drag the LDL into the hepatocyte. The blue is the LDL RAP1, which helps in the internalization of the LDL particles. And the PCSK9 enzyme is something which degrades the LDL receptors and prevents it from being reused again. And so this schematic helps us understand where some of the drugs that we're going to be using or talking about today, especially the PCSK9 inhibitors, actually work. And they work by inhibiting this enzyme and allow the LDL receptors to be recycled and reused, and thereby they're able to get in more of the LDL particles into the liver and decrease the blood levels of LDL. If you look at the genetics, you'll see that the commonest genotype abnormality is the LDL receptor, which is available on the chromosome 19 and forms most of our cases, almost 80% of the FH cases, followed by ApoB on chromosome 2 and the PCSK9 on chromosome 1. The LDL-RAP1 gene that we talked about is an extremely rare condition. Now, we'll be looking at this a little later. Those patients who have a definite FH will have a higher yield when you genetically test them, because we know genetic testing is expensive. So it's important to see which clinical population can it be actually used in a cost-effective manner. The inheritance of this, if it is one mutated allele, is in the heterozygous form, and if it is two, it is in the homozygous form. What it also involves is an elevated level of lipoprotein A, usually more than 50, an elevated triglyceride-rich lipoprotein remnant, and dysfunctional HDLs. What that happens as a mixture is that it contributes to accelerated atherosclerosis and coronary heart disease. The data which is available is that every 10 milligram increment of non-HDL is equivalent to 1 year decrease in the lifespan. Now, when you look at the biology of atherosclerosis, while we are aware of dyslipidemia and high LDL levels and elevated LPA, we must realize it is just one of the many that is important for atherogenesis. So it is very important as clinicians, while we are focused on LDL and lipids, that we need to not forget that there are so many other factors that need to be looked at when dealing with patients. Now, this is a schematic showing you how homozygous FH appears very early in the lifespan of an individual. At about 13 years of age, the elevated LDL shows up as a clinical coronary heart disease. In fact, there are reports of anything between 2 to 20 years where homozygous FH can actually manifest. A little later, at the age of 35, is when the heterozygous form actually starts appearing. And then there's a variable expression depending on the level of LDL and also when in the life course the statin has been applied and also how high the dose was. And the green is the traditional form of an average person of how he presents with coronary artery disease at around 55 years of age, subject to the various other risk factors that are associated with this process. So just to summarize, you can see that homozygous FH presents extremely early at about 12 years of age, and at about 30 years of age, we find the heterozygous presenting, which cripples people at a very, very important time in lifespan. If you look at FH in terms of the frequency compared to the other genetic disorders, including Duchenne, cystic fibrosis, and Huntington's disease, you will see per 1,000 fairly high representation of almost 5 per 1,000 births, which makes it one of the most common genetically linked diseases. There is also the effect, and you saw that in the world map, in small places in South America, South Africa, and in Canada, where a small group of people with a high frequency of the genetic mutations establish new populations and live in a certain isolation. And this has been seen in the French Canadians, the Ashkenazi Jews, and the South African Afrikaners. And because of the inbreeding in these populations, you find that there are clusters in about 1 in 300 patients. In ischemic heart disease, it's there in about 1 in
I think some network problem is there, sir.
Yeah, I think some bandwidth problem.
You can tell him to switch off this video so that he can talk. Christopher, can you switch off your video so that you will have an access to the audio?
I think sir has logged out, sir, and he will again rejoin, sir. Yeah, sir has joined.
Joined, huh?
Yeah, yes, sir. Sir, you are muted, sir. Christopher, sir.
Christopher, you are muted.
Please unmute and share your slides. So Christopher, please unmute and join. Share your slides.
Am I audible?
Now audible. Yeah.
Audible, sir.
Yeah, you can share your screen now, please.
So for what Dr. Narsingan was telling, if you switch off your video and show the slides, then it will be easy, so that the bandwidth problem will not occur.
Yeah. Yeah. Now it is visible.
To be switch off your video.
Visible,
Okay,
visible, Christopher.
now?
Please go ahead.
Okay. Yeah. So you can see on the left side is the Achilles tendon xanthomas, and on
Christopher, can I request you to switch off your video, concentrate only on audio, please.
am I visible?
Yeah, that's okay.
Am I audible?
Audible.
It's very clear.
Okay, so this is a slide showing us a very aggressive course of a patient with familial hyperlipidemia, where you see that this patient had 2 bypass surgeries starting at the age of 23 and then 36, followed by a PCI, and finally had a critical severe calcified aortic valve stenosis with diffuse atherosclerosis across his entire aorta. And this unfortunate patient unfortunately had a sad demise waiting for a TAVR procedure. And you can see on the left corner that his cholesterols were markedly high, including the LDL cholesterol. So this is a typical example of a very aggressive and premature atherosclerosis in these kind of patients. When you look at the diagnostic criteria, there is a clinical and a genetic criteria. The clinical criteria involves a lipid panel along with a family history of both first, second, and sometimes even the third generation family, along with a physical examination looking at some of the signs that we have just seen, followed by the criteria, the Simon-Broom criteria. There's a Dutch criteria, a MedPed, and also a homozygous criteria. The Simon-Broom criteria is the one which is well accepted because it's easy to do in the outpatient. There's a genetic criteria which uses either a microarray with known mutations or a sequencing which is a little more difficult with unknown mutations. Now, the Simon-Broom criteria has taken center stage definitely 0.1 with either 4 and or 5. The first point is a cholesterol level in adults more than 290 with an LDL more than 190, and in young adults less than 16, 260 total and 155 of LDL cholesterol. The second criteria that has to be added is the tendon xanthomas, which I showed you, which is an important thing both in the patient or in the first or second degree relative. The third is an optional criteria which involves genetic analysis. And the probable criteria involves number one, which is the total and the LDL cholesterol, along with a family history of an MI, either at 50 years in second degree or at 60 years in a first degree relative. Now, the LAI recommendation for the diagnosis recommends universal screening of all individuals prior to the age of 20 years or at the time of college entry or earlier, anytime after 2 years to 20, if there is a strong family history of heterozygous or homozygous FH or premature CAD, as we have discussed, less than 50 or less than 60, depending on the generation of family. The LI also recommends, as I showed you, the Simon-Broom criteria because of the ease of remembering it in a busy outpatient. Cascade screening, which involves first degree, second degree, and third degree relatives, is recommended. And there is also a note that we need to include serum LPA in the screening. More than 50 is important. The other important thing is cascade testing. So once an index diagnosis is made, a clinical or genetic testing should be done. The other risk factors need to be medically looked for and treated. Drugs like statin, estimab are the standard drugs to start off with, and we slowly move on to the PCSK9 inhibitors, which are the next level. Plasma apheresis in those patients who do not respond to triple drug therapy, and obviously in rare cases as a last resort, liver transplant. Now the data with high dose statin, defined as rovastatin, more 80% survival high-dose statin, 80% in those who were not put on statin, showing the survival advantage with high-dose statin. The TOSIC trial, which was an open-label single-arm study with 3 patients with a mix of both homo and heterozygous FH over a 4-year interval, showed the first drug, evolocumab, which was evaluated for use in this condition, to have a significant 30% reduction in homozygous and almost a 55% reduction in heterozygous group. And at the end, almost a third of the patients needed to stop apheresis because LDL was well controlled and the CVD rate was brought down to 2.7 per year. The second study was the Odyssey homozygous trial, where patients with homozygous FH was used, and the second PCSK9 inhibitor, alirocumab, which was used for this purpose at a dose of 150 milligram every 2 weeks. And here there was a double-blind portion where you had the PCSK9 and the placebo, and you can clearly see the LDL coming down with the PCSK9 by almost 30% with no improvement in the placebo. At the week 12, when almost 30% reduction was seen, then the patients on the placebo arm were also given alirocumab in an open label format, and there at week 18 showed a dramatic decrease in LDL, however could not match the patients who were already on the drug from the beginning, showing that a more than 30% reduction was seen in LDL cholesterol in the alirocumab arm, and even patients on placebo, when you could start it later, also did respond, showing the real well-tolerated and safety of the drug and the efficacy as well. The Orion 9 trial in heterozygous group again used a new drug called inclisiran, which was an RNA-based drug targeting the hepatic PCSK9 synthesis. And these prevented the PCSK from being formed, and thereby the LDL receptors were frequently recycled and were available at the receptor site to take in the LDL. And clearly you can see here that there was a 40% decrease in the LDL in the inclisiran arm over a period of 5 years. And the absolute LDL also came down to under 100, somewhere between 80 to 90. And this effect was prolonged over about 3 to 4 years when the drug was continued. So this again showed the safety of this RNA-based drug, causing a marked decrease in LDL cholesterol in this group. Yet another drug which was evaluated was ivanezumab, again targeting the ANGPTL3 receptor and thereby reducing the LDL cholesterol by almost 40 to 50% over a 1 year period. And here it was seen that even though patients were on triple drug regimen, that is PCSK9, estimab, and high intensity statin, they also got a significant reduction. And even those who were on regular apheresis also got a reduction over and above that treatment when the drug was given over a 4-week period from week 4 to week 24, showing the marked reduction in LDL even on top of very, very good therapy. So the NLI expert panel then gave a recommendation for apheresis therapy in homozygous patients, that they would start apheresis if the LDL cholesterol exceeded 300 even on top of medication, and the heterozygous group would also be started on apheresis more than 300 if they were unresponsive to drug therapy, or they could be started even at a level of more than 200 if there are 2 risk factors for CVD, or an LPA level of more than 50, and that's why the recommendation for LPA also came in as part of the screening, or an LDL more than 160 when there was established ACVSD or diabetes. The LI recommendation in 2017 for LDL goals were in children less than 70 in the homozygous group, less than 100 in the heterozygous group, and in adults, a lower mark of less than 50 in the homozygous and less than 70 in the heterozygous, clearly showing the intent of reducing risk, or a reduction of more than 50% in total LDL. The recommendations of the LI in 2020, again in those patients with established atherosclerosis in the heterozygous group was less than 50, 30 was optional, and in patients with homozygous, it was actually less than 30, and this was the first time a recommendation of less than 30 was done. This obviously has to be a shared decision with the stakeholders and the patients. In conclusion, familial hypercholesterolemia, both homozygous and heterozygous, is a fairly common but potentially lethal genetic disorder. It is frequently underdiagnosed and also under treatment. Protocols which are in place are generally not used. There are clinical grounds of suspicion which can be easily looked at and focused. Cascade screening, which involves screening the first, second, and third degree relatives, is essential to make the diagnosis. There are a number of therapeutic options available, including estimab, high-dose statin, and PCSK9, and the RNA inhibitor group. It is also important to remember that these patients get atherosclerosis very early, so the other risk factors, including tobacco use, diabetes, and hypertension, need to be controlled aggressively. The take-home message from today from the LII is please spread the word that homozygous and heterozygous hypercholesterolemia can be detected easily and can also be treated. Thank you very much for your kind listening.
Thanks, John, for an excellent and lucid presentation, and especially the message from Lai that spread the message is very important, because all of us still continue to miss this case of familial hyperlipidemia. Dr. Harish, you want to take the questions now or in the 3 sessions?
We'll take the questions at the end of all the 3 presentations. Sir.
Okay.
We'll have a discussion.
Probably next, you can go ahead with the next talk, I think.
Yeah, thank you so much.